Role of PET-CT scan in the evaluation of colorectal cancer, CRC. PET-CT, positron emission tomography computed tomography, plays a crucial role in the diagnosis, staging, treatment planning, and follow-up of colorectal cancer. By combining metabolic imaging with anatomic detail, PET-CT provides a comprehensive assessment of the disease. Below are its specific roles in CRC evaluation. 1. Initial staging. Detection of primary tumors. PET-CT, especially using fluorodeoxyglucose, FDG, as a tracer, is not typically used for detecting the primary tumor since CT or MRI is generally sufficient. However, it may be useful in ambiguous cases where conventional imaging is inconclusive. Lymph node involvement. PET-CT helps in identifying metabolically active lymph nodes, which may indicate metastatic spread. It is more sensitive than CT in detecting small active nodes. Distant metastases. PET-CT excels in identifying distant metastases, particularly in the liver, lungs, and bones, where metabolic changes occur before structural changes are visible. 2. Treatment planning. Surgical planning. By accurately delineating tumor spread and metastases, PET-CT helps surgeons decide the extent of resection required and whether metastasectomy, e.g., liver or lung resection, is feasible. Radiation therapy planning. PET-CT helps in defining the metabolic tumor volume, which can improve targeting during radiation therapy, sparing surrounding healthy tissue. 3. Detection of recurrence. Elevated tumor markers. In patients with rising carcinoembryonic antigen CEA levels but no evidence of disease on CT or MRI, PET-CT can localize recurrence, including in areas like the liver or retroperitoneum. Local recurrence. PET-CT is sensitive for detecting local recurrences at the anastomotic site or within the pelvis, particularly in cases where post-surgical changes obscure conventional imaging. 4. Assessment of metastatic disease. Characterization of liver lesions. PET-CT can differentiate between benign and malignant lesions in the liver, which is a common site for colorectal metastases. Extrahepatic disease. PET-CT identifies metastases outside the liver, which can alter treatment plans significantly, such as shifting from curative to palliative care. 5. Monitoring treatment response. Chemotherapy or targeted therapy. PET-CT is highly sensitive in detecting changes in tumor metabolism after chemotherapy or targeted therapy, often before anatomical changes occur. Early response evaluation. Early metabolic response on PET-CT correlates with long-term outcomes, helping guide therapy modifications. 6. Prognostic value. The metabolic activity observed on PET-CT, quantified as standardized uptake value or SUV, correlates with tumor aggressiveness and prognosis. High SUV values often indicate a worse prognosis. Number 7. Evaluation of uncertain lesions. PET-CT is particularly valuable in differentiating post-surgical scarring or radiation changes from recurrent disease, as scar tissue is typically metabolically inactive, whereas cancer exhibits high FDG uptake. Limitations of PET-CT in CRC evaluation. Low sensitivity for small lesions. Lesions smaller than 5 to 10 millimeters may not be detected due to limited resolution. False positives. Infections, inflammation, or granulomatous diseases can mimic malignancy. Expense and accessibility. PET-CT is costlier and less widely available compared to CT or MRI. Conclusion: PET-CT is a valuable tool in the evaluation of colorectal cancer, providing crucial information for accurate staging, detecting recurrence, and guiding treatment strategies. While not universally indicated for all stages of CRC, it is particularly useful in complex cases where conventional imaging is insufficient or when a comprehensive metabolic and anatomical assessment is required.